Okay, I think we can start as people are slowly joining. I think the um, recent Legendo sessions have been more um because people have realized that we post these online, so they don't necessarily make the effort to come and join on the day. I think we should perhaps think about that and make it either delayed posting on thing or make it more engaging for people to have a better reason to join on the day and in the
Mm.
hour. But we can discuss that. Right. Okay. Good evening, good morning, wherever you are. I can see that there are people from various different places joining. Welcome to another session of Legendo Lister Endometriosis Journal Club. Um, we have these journal clubs at 6 p.m. On the 6th of every month. We've been doing that now for 2.5 years. Yeah, it's coming to 2.5 years. So we've missed one or two, so I think this may be the 28th or something like that. The idea of Legendo is that we want to make journal clubs less boring, so very quick to the point, 3-4 minutes for each paper. But we will also have one author of a recent paper who will present their own work, and that will be a longer presentation. And today we have Georgios Grigoriadis. I did try to say that right. I think I got it right in the end. From Thessaloniki, who published recently with the group of Professor Roman a very interesting paper on AMH and endometriosis surgery. We're going to hear all about that. Legendo is supported by Karl Storz UK, and we are very grateful to their help in coordinating this and designing the brochures. And hopefully we'll continue with this collaboration with Karl Storz. A couple of other points to make. One is that we don't necessarily share the views or opinions that are presented in this forum. These are scientific papers. I know that for the clinicians on the meeting, that is obvious, but sometimes we have patients who join us. What we are presenting doesn't mean that this is the correct thing and this is what we agree with. Um, this is how science works, that you have papers showing different things, and then the next research will come and show the complete opposite. And it sometimes will take years for us to know what the real answer is. Um, do post your questions in the Q&A session at the bottom and at the bottom even. Um, you know the team by now, hopefully. We have Florence Britton, who's my current fellow, who really coordinates Legendo this year and has done a lot of work in making this happen. Ben Mondelli is a consultant colleague in Guildford. Kyle Fleischer is my previous fellow, who is now senior trainee in Frimley, and Sarah Rizak is also one of the trainees at St. Peter's. And I'm very grateful for all of the team for doing their bits and presenting the articles. So let's start from the first paper. I think that's you, Sarah, or
This
I.
one is me. This one's me.
Okay, all right. So
Hearing
I.
me okay? So this was published by a group from Melbourne, Australia. This study focused on whether PET scans can offer additional diagnostic value in the assessment and diagnosis of endometriosis. So moving to the next slide, this was a review article and evaluated 8 cohort studies involving 110 participants to determine the utility of PET imaging in detecting and monitoring endometriosis. Positron emission tomography is a non-invasive imaging technique that uses radio tracers to highlight areas of increased metabolic activity. It's widely used in oncology, but its application in endometriosis is not known. It's certainly feasible, however, given that these are inflammatory lesions and are likely to have higher metabolic activity, that PET may play a role in diagnostics and monitoring. The results showed that the correlation between the PET tracer uptake and histologically confirmed endometriosis lesions range from 0 to 55% on a per lesion basis, and on a per patient basis, this ranged from 0 to 82%. The commonly used 18F tracer showed inconsistent results, while an alternative one, 68GA, showed some promise for detecting deep endometriosis, but with limited sensitivity and moderate specificity. However, the review highlighted significant limitations, including small sample sizes, inconsistent timing of scans, and variability in diagnostic criteria. So we're going to have a little deeper look at the study design. So this slide outlines the inclusion and exclusion criteria for the studies, along with an overview of the traces evaluated. The study included participants with known or suspected endometriosis who underwent PET imaging. This could be standalone PET, PET CT, or PET MRI. Exclusion criteria ruled out case reports with fewer than 5 participants, as well as reviews, expert opinions, and non-English language studies. The review primarily evaluated two traces because this is where the most evidence was. The widely used 18F targets areas of increased glucose metabolism, but its results were inconsistent. An alternative tracer, 68GA, targets somatostatin receptors and showed potential for detecting deep lesions, although its sensitivity and specificity were limited. The review also discussed two novel tracers, something which may hold promise for future studies. So one is the 18F-FES. This tracer binds to estrogen receptors, making it particularly interesting for imaging estrogen-dependent conditions like endometriosis. Early data suggests it may distinguish active endometriosis lesions from scar tissue or adhesions, and another called FAPI, which is fibroblast activation protein inhibitor, and which targets fibroblast activity, which is involved in inflammation and tissue remodeling. Though primarily studies in cancer, its role in endometriosis remains to be explored. Moving to the next slide, the actual findings that they were able to get from the traces that were used. There was, in terms of the 18F FDG imaging, the detection rate of endometriosis lesions was inconsistent, ranging from no detection in some studies to a maximum correlation of 55%. The 18F FDG is a glucose analog that highlights areas of increased metabolic activity commonly associated with inflammation or cancer, whereas the 68GA targets the somatostatin receptors, which are present on neuroendocrine differentiated cells and lymphocytes. In one study, this tracer detected 33% of endometriosis lesions with higher sensitivity and specificity for deep endometriosis at 57 and 80% respectively. It's really important to say that these results are based on a very small sample size and need further validation. So useful study from one point of view, it's tried to summarize all the evidence that's available, but right now PET does not appear to be useful with regards to diagnosis and monitoring of endometriosis, although with new tracers, new agents, and the combination of MRI PET, this may change in the not too distant future. I think one application that seems promising is, especially if someone's had previous excision surgery, could there be a role for PET imaging and looking for what could be described as active lesions versus fibrosis and adhesions?
Okay. I think it was interesting that they sort of doing PET, but when I saw this paper, I couldn't really understand what it is that they're trying or hoping to achieve. It's a bit like saying, can you go to the shops at the end of the road with a helicopter? Is it feasible? Well, it may be feasible, but why would you want to do that? That I didn't get. And also, given the fact that PET is both, correct me if I'm wrong, you may know this, both more expensive, there is a bit of radiation, and even if it tells us a yes and no that there is a disease, it's not going to give us the precise depth of the disease because it doesn't actually see high quality images of the bowel wall, for example. I don't understand what use it could have, even if they showed. So it needs to be much better than what we already have to justify using a more expensive with radiation modality. Or did they explain their reasoning behind, what even theoretically could be useful?
So the rationale, so this study was simply to look at what was available and summarize that evidence.
Hmm.
Um, Seemingly, the rationale from previous studies and the timing of studies varies, but obviously, our non invasive diagnostics have improved quite significantly even the last 5 to 10 years.
Hmm.
Um, the other preliminary studies or the smaller studies, I think we're mainly looking at what do we have now that is used widely, for example, in oncology, and is there any current clinical application for endometriosis?
Okay.
And then these authors have summarized
You
what's
always
there.
need a group of people who do studies that are not seen easily as logical, because that's where the breakthroughs can come from, so don't get me wrong, I don't think that kind of study shouldn't be done, but I couldn't explain it with my logic. Okay, perfect. Sarah?
Hi, so I'll be taking you through a paper that looks at artificial intelligence for doing grading of your postoperative complications using the Clavian-Dindo classification. The objective of the study was to understand if ChatGPT, so that was the AI they used, whether by feeding it with natural language processing, so basically by feeding it information verbally, it was able to grade your postoperative complications using the Clavian-Dindo classification system, which is a system coined by the surgeons, but a lot of us use it in gynecology as well. And they basically wanted to see if AI was better at doing this grading, whether we could streamline our clinical outcome reporting, and whether it was better than a human at doing this sort of task and this grading system. They tested versions 3.5 and 4, and they fed it information through clinical discharge letters, both fictional and real. And their overall results were basically that ChatGPT had a 99% agreement with the human operator in grading postoperative complications. And basically, it had a near perfect performance to humans. It is proficient and it is accurate to use basically ChatGPT 4 was their overall conclusion. But I'll take you through some of the details. Next slide. So it was a prospective data collection, and they did a comparison between ChatGPT 4 and 3.5, and then ChatGPT versus a human grading as the reference standard. And they ran 3 basically diagnostic test evaluations, and then did a statistical analysis on these, which I'll take you through. Next slide. So the first thing they did is they tested whether ChatGPT could basically define the Clavian-Dindo grades. The Clavian-Dindo grades are from 1 to 5, according to how much a patient's postoperative course deviates from the norm, and sort of how much intervention is required, pharmacological or ultimately a return to theatre, or grade 5 where the patient results in death. And here you can see in the comparison that ChatGPT 3.5 was a complete flop. It was just unable to define the postoperative grades. ChatGPT 4, on the other hand, was very accurate to 99%. So 69 out of 70 times it was able to produce the exact definition according to Clavian-Dindo. The next test they went through was basically they fed the AI with information from discharge letters, both fictional and real ones. And they compared it to a human operator as to how accurate it was at doing the grading. So again, ChatGPT 3.5 was a complete flop. It was just unable to even differentiate grades, let alone subgrades. So no further statistical analysis was done there. Meanwhile, ChatGPT 4 had a 97% accuracy in being able to define single complications. They did a Cohen's Kappa agreement to basically compare with a human operator, and the agreement was nearly 1, so it was very, very good. With the fictional vignettes, what they did then was they fed the AI the same information 3 times. And interestingly, they were actually looking for one of the major flaws in AIs, which is basically generating AI hallucinations. So when you feed the same information, it did 1 out of 3 runs, it did give different gradings, or actually it made fictional nonsensical gradings of 1B, for example. And these are called AI hallucinations. And that is one of the flaws with AI in general. With real discharge summaries, it matched 43 out of 45 complication grades. So again, it was overall relatively accurate, and it had an inter-rater agreement in this case of 0.92. Next slide. So then they essentially discussed the results, and overall, we can say that ChatGPT 4 was very good. It outperformed 3.5, and it was very close to a human operator. The main issue was these AI hallucinations, and also they identified the risk of AI bias. So AI has a degree of sort of learning and feedback from what we humans feed it. So what happens is when they gave it the fictional vignettes, because certain complications were underrepresented, the AI was then less able to grade those complications. They identified the risk of AI hallucinations as well, as we've said. So it isn't 100%. It can generate nonsensical information. And the main risk there is that the information can look real. So it generated a grade 1B complication, which could look like a grade, but actually it doesn't exist. And it's very hard to spot. So they identified the importance of needing a human operator to always have oversight of an AI, basically. And one of the main limitations of their study was their vignettes were basically biased, because they made these fake vignettes knowing they were going to put it into an AI. So there wasn't that real ambiguity of a real discharge letter, for example. And 6 cases was pretty low. Interestingly, they timed as well how long it took for the AI to come up with the grading, and it was fast. It was 33 seconds per vignette. And so they saw the potential of being able to use AI across, for example, different centers. One of their limitations was that surgeons also use a CCI, which is a next level to their postoperative complications, and this wasn't integrated. Next slide. And so, yeah, overall, ChatGPT 4 has a high fidelity to human operator in classifying your postoperative complications, definitely could support us in audit, in training, and in research, but humans always need to be in the loop. They've really shown that. They have raised the concern in AI in general is, how do we input our patient data in a way that's ethical, and do we need to anonymize the data before putting it through the AI? And they definitely showed the importance to the need to train AI and refine it, give it as much feedback as possible to reduce AI hallucinations and AI bias.
Very good. Okay, thank you, Sarah. Do you know, I don't know if you know this, but we are doing a similar study for staging endometriosis using AI. So maybe it's a good paper to learn from, or maybe learn from its mistake. Did they give the AI in each prompt the description of Cleviandindo, or did they rely by the knowledge of ChatGPT?
So right at the start, the first thing they did was, yes, they trained it into saying what the grades of Cleviandindo were, and then from there they did the next tests.
Okay. Yes. Now, another point on Cleviandindo is that I really think we need another one for gynae and particularly for endometriosis. I don't think it's a good system for what we do. But having said that, me and Flo had put some things into ChatGPT to see what Claviandindo it comes up with, haven't we, Flo? So for example, we asked what is the Claviandindo? Maybe Ben and Kyle, both of you can tell me what you think. What is the Claviandindo for a patient who had urinary difficulty, voiding difficulty, and needed to self-catheterize for 2 months? How do you stage that?
I would call that a 2.
Okay. Why?
It's
So if I
pharmacological.
had to broadly describe them, I would say 1 is an intervention that you need to do at the bedside.
Mhm.
2 is something slightly more significant in that you might have to go away, come back. There is something that you need to take or do with you. And a 3 is a return for a procedure. So what you described there, I would describe as a 2. And appreciating what you've said, that some things don't fit in very well.
Mm.
I would have said 1
Yeah.
actually.
So interestingly, on this paper, the
Exactly.
errors that they had was with urinary catheterization grading.
Uh-huh.
So
Well, yes. So yes, so we gave this to ChatGPT. It said it's a 3A. Then we went and read Claviandindo, and it was very clear that 3 is for radiological, surgical, or what was the other one, Flo?
endoscopic.
Endoscopic, yeah.
Endoscopic interventions, and catheterization is neither of those. It doesn't feel like a 1, so I would agree it needs to fit into 2, but actually, if you go by the wording of Claviandindo, it will be a 1, but I'm not comfortable with it being 1 because to me it's more of a big deal, than a Claviandindo 1. But anyway, that's why I think it's not perfect. So, all right, now what everybody has been waiting for. Um, so Georgios is going to talk to us about their work. So Dr. Grigoriadis works in Thessaloniki, north of Greece, in Aristotle University. I love the city. I've been there a couple of times. I was supposed to go there a couple of months ago, which I couldn't manage. I'm very interested in hearing this, and I think it's going to create lots of discussion. Particularly AMH is something that all of us struggle with understanding. I have to say, this is probably one of the most misunderstood tests that we run. Please.
Dr. Ghazali, thank you so much for the kind invitation. It's a great honor and a pleasure for me to be part today of this wonderful initiative that you've initiated a few years ago and has been joining a lot of success over the years. So I'm hoping to give a presentation that will be useful to our attendees today. I'm just going to start by sharing my screen now. Let me just have a look. Share. Can you see that?
Yes, perfect.
Yeah, that's right. Okay, so I'm just going to start now. So thank you so much again. Today I have been asked to present a recent publication called Evidence on Serum Antimalarian Hormone Levels and Endometriosis Surgery, which is a review article. It is not new knowledge in any way. I have to stress that right from the beginning. And it's, of course, a fruit of, as it usually is, a collaborative team effort between clinicians from different units, with senior author being my mentor, of course, Professor Oras Roman. Relevant to this publication and presentation, I have no conflict of interest to declare. Now, when we started writing about the paper, I spoke to Professor Roman and we said, look, everybody would be interested in that topic because one, Endometriosis is a prevalent disease. Number two, infertility rates are on the rise, and a lot of patients want to assess their fertility by doing simple tests that are marketed as being, a fertility checks, such as anti-Müllerian hormone levels. Therefore, everybody would probably be interested in knowing how does the endometriosis disease per se affect the levels of AMH. How does surgery for endometriosis affect AMH levels? And could we then be using those levels before and after surgery in order to predict the fertility outcomes for those patients? A few things about this paper. We started in our introduction stating things about anti-Müllerian hormone. As Dr. Casali rightly said, it's a very confusing molecule, I think. We know that it's produced by the granulosa cells of the pre and small antral follicles. It regulates ovarian folliculogenesis, preventing a premature exhaustion of the follicular pool. But in the daily clinical practice, it is thought to be a useful ovarian reserve marker because it's a blood test, it's objective, it's available in most countries in the world. Maybe not reimbursed by all healthcare systems, but relatively cheap. And apparently it can be done on any day of the cycle, and it may not be affected by the use of hormonal contraception. Of course, it's not the only ovarian reserve marker. We have others like AFC, ovarian volume, etc. AMH levels tend to decrease with advancing age, and low AMH levels, according to some evidence, have been linked with a younger age of menopause. But when we look at AMH and its role in reproduction, I think it's very pertinent that right at the start we draw a line and differentiate between its use in the ART protocols and its use in the spontaneous conception setting. In the ART protocols, there's plenty of evidence suggesting that AMH is useful in predicting the ovarian response as part of the controlled ovarian stimulation protocols. However, when we're talking about spontaneous conception, a lot of studies suggest that it has limited, if any, role in terms of predicting the reproductive potential of the woman. And of course, those studies did not focus or actually did exclude endometriosis patients. So there's a paucity of data there. There's not a lot of data. We know about endometriosis. It's a benign disease of unknown etiology. It's linked with infertility as a reduced fecundity rates are observed in untreated patients. And the main thing when I think of endometriosis, I think it's a very heterogeneous disease. I think this is the key word that is important about this disease. We recognize three phenotypes broadly: superficial disease, ovarian endometrioma, deep endometriosis, and of course we have the various staging and classification systems that I don't have the time to go into much detail now. We did a literature review. As I said, this is not original data, of course. We limited our search to English language articles using the usual data online database, medical databases. We looked at articles from the 21st century, original and review articles, meta-analysis, etc., excluding abstracts from conferences. Moving on to the results of our paper, I start by this study. It is a very generic study. I think it's an interesting one, but it's a very generic. It's recently published in Maturitas from the Nurses Health Study 2 group. The authors asked the members of the cohort by sending them questionnaires as to whether they've had a history of laparoscopically confirmed endometriosis. In the average age of 40, they found out that patients that answered yes to the questionnaire tended to have a 30% lower AMH value compared to those that answered no to the question, a finding that did not vary by parity on infertility history. Of course, various limitations really need to be taken into account, such as the fact that they did not really take into account the severity, the extent of the disease, what exactly happened at the time of surgery, nor did the controls have endometriosis ruled out by laparoscopy, meaning that there's potentially a number of limitations in that finding, which is, however, significant. We know that endometriosis causes infertility by a number of mechanisms. I'm not going to spend time here, but how does endometriosis cause a reduction in AMH values if it does? This is less clear. but postulated mechanisms include chronic inflammation and resulting oxidative stress coming from chronic inflammation. Potentially, in more severe disease stages, increased apoptosis of the granulosa cells, potentially exhibiting a burnout effect, may be similar to the gonatotoxicity arising from chemotherapy in cancers. But looking at the various phenotypes, let us have a look at superficial endometriosis. We have some studies that concluded that actually this type of disease does not relate to lower AMH values. For example, this case control study by Lessons and co-workers found that there was no statistically significant difference between patients with superficial endometriosis and controls. Other studies found the same in patients with mild endometriosis and controls. And also that other study that looked at infertile patients undergoing an IVF, they did not focus on the serum, but actually on the follicular fluid, and found that the follicular fluid between endometriosis patients, infertile endometriosis patients, and other infertile patients that are endometriosis free had no difference in the concentrations. But that is not by no means universal finding. We have findings such as this by Lemos that found that patients with a mild to minimal endometriosis, infertile patients undergoing ART, have statistically significant lower AMH values compared to controls, which are tubal factor infertility patients. And the finding of this, all the study infertility and sterility, was recently supported by a laboratory rat study that found that when the authors injected somehow superficial endometriosis lesion to rats, that led to a measurable decline in the rats' AMH values. But of course, the majority of the evidence revolves around ovarian endometrioma. Now, we have, rather convincing evidence to say that the presence of endometrioma per se causes a reduction in the ovarian reserve. We have the very well-known meta-analysis by Ludovico Mucci. This is not new stuff. He found the patients with endometrioma compared to patients with no endometrioma and compared to patients with other types of benign ovarian cysts have a lower AMH value. And it may not only be that static lower AMH value, but it also may be that patients with endometrioma have a higher rate of AMH decline over time. I'm drawing your attention to this prospective Turkish study. They found that over a 6-month period of time, patients with endometrioma experienced a higher decline of AMH compared to controls, with the effect being more significant for patients with bilateral disease. The laterality of OMA, unilateral or bilateral, comes back again and again. For example, in this Asian observational study, they also found that bilateral endometrioma patients have lower AMH values compared to unilateral disease. What about deep endometriosis? Now, of course, it is not feasible, I would say, in my mind, or it's extremely difficult to just draw definitive conclusions about patients who have deep endometriosis only, because a large proportion of those will have, coexistent ovarian endometrioma, and some sort of surgical intervention will occur to the ovary. So it's difficult to say, but in any case, with that in mind, Pancherotti and co-workers, the Italian group, when they compared deep disease, advanced stage disease with healthy controls, demonstrated that the first group, those with advanced stage disease, had lower AMH. Also another study looked at patients with ovarian endometrioma that find that when the patient had stage 4 disease with ovarian endometrioma, the AMH values for stage 4 disease were significantly lower compared to controls, compared to stage 3 disease, where that was actually not the case. That with the disease per se. In our paper, we also looked at how does endometriosis surgery affect the AMH values. Of course, there's a huge amount of publication on what happens with ovarian endometrioma surgery and where this is the majority of the data comes from. We know that we have various approaches. Traditionally, the gold standard has been and probably still is in most parts of the world ovarian cystectomy for endometrioma. We have that Cochrane review back from 2008 by Hart and co-workers, which stated that cystectomy is superior in terms of spontaneous conception rates, in terms of reduced recurrence rates, in terms of symptomatic relief. So we really steered towards cystectomy. But then as time went by, there were a lot of concerns regarding reduction of the ovarian reserve, ovarian volume, even some cases of surgical induced menopause after ovarian cystectomy, that led to the development of various non-excisional approaches, hoping to spare the healthy ovarian parenchyma. I will just mention here that we have approaches of simple drainage. We have mostly ablative approaches, all the bipolar approaches, and more sophisticated nowadays, such as various types of laser, diode laser. Of course, we have plasma energy. We have combined approaches, meaning cystectomy and ablation close to the hilum. We then have sclerotherapy approaches, three-step procedures. We have a lot of ways to try and reduce that. But what does Ezra say? We says that regarding AMH, well, it doesn't say a huge deal. It says that if you decide to perform surgery, you may better take into account the ovarian reserve. A strong recommendation to say that do not do surgery routinely before IVF because it doesn't particularly help and it's likely to hamper the ovarian reserve. And then when you decide to perform surgery for ovarian endometrioma, make sure you minimize ovarian damage. So that's all reasonable, I would have to say about this. But let's see what the evidence suggests about original papers and stuff. We looked at original papers. We actually looked at meta-analysis here. We have a couple of meta-analyses that demonstrate clearly that cystectomy for endometrioma does induce a reduction in the ovarian reserve. We have the one by Francesca Raffi, and we have the Somigliana as well, meta-analysis. For example, in the first meta-analysis here that I put by Francesca Raffi, at all times, cystectomy led to significant decline compared to the preoperative values, as you can see here, despite the high heterogeneity of the studies. When they looked particularly at studies with a high preoperative AMH, more than 3.1, the main finding persisted. Okay, and for cystectomy, it's particularly important to say that comes back again and again. It looks like the drop in the AMH is more likely to be more profound in the bilateral group. Johnny Eunice and co-workers demonstrated that, and that probably does not only relate to the early, but maybe extend to the intermediate and late postoperative period. Bilateral cystectomy is probably more harmful. I'm only examining from an AMH point of view, of course. It could be that other predictive factors are also important. Pre-op AMH value. For example, in the recent publication by Andrienne Crestani and Ras Ruman, this is not about cystectomy, this is about sclerotherapy, but they demonstrated, but the higher the preoperative AMH value, the more the drop in the AMH value you might experience after surgery. So that may well be the case in cystectomy as well. Age may be an important factor, duration and complexity of surgery, stage of endometriosis. Lots of studies suggesting that the more advanced the disease, the more advanced the adhesion lysis, you may anticipate more of a drop in AMH, and also the size of endometrioma. This is a hot topic as well, as to whether that causes a more decline in AMH. Hemostasis methods. Okay, I hope I'm not going too slow. I'm trying to make best use of my time. Well, with hemostasis methods, this topic has been really well studied, really. All the meta-analysis from a number of esteemed authors demonstrated superiority of non-ablative approaches, be it predominantly sutures or some various forms of hemostatic sealants compared to thermal methods in terms of the AMH, a finding that may persist according to this meta-analysis up to 1 year after surgery. However, I also need to mention a couple of more recent RCTs that came after those meta-analyses that may question actually those findings. For example, this Brazilian study, the first one on the left, they found three groups: use of bipolar, use of hemostatic sealant, and use of suture. Compared the AMH before 1 month and 6 months after surgery, they actually found no significant differences between the approaches. And then that other lovely study in the British Journal of Gynecology, comparing FlowSeal for hemostasis versus bipolar. Look at that. They also did not find significant differences in terms of AMH pre-op 1 month or 3 months after surgery. It may well therefore be then other factors are equally important, such as, for example, the settings of your bipolar, judicious use with less time, less number of applications, and also things like suturing that may have been thought to be, a lovely way of preserving the AMH, may induce some form of necrosis as well that may also reduce the AMH. So these are things that are not particularly, 100% clear, but just food for thought, really. The other thing to say really is the recovery of AMH. So this is a very important thing. If we accept that, cystectomy causes a decline to a certain extent, do we anticipate that it recovers? The answer from a number of observation studies is probably it does. Reassuringly, it looks like it does. Okay, this is an interesting study, a retrospective study by Michele Vignali, Italian group. What they demonstrated, look, is that when you do a cystectomy, you anticipate a drop in the AMH 1-3 up to 6 months, but then at 12 months, it appears to recover to levels that are not statistically significantly different, actually pretty similar to the preoperative values, suggesting that you almost have a full resolution of the AMH drop. And it was also interesting, they also demonstrated that this finding persisted even for bilateral endometrioma cystectomy, which I found particularly interesting, although they demonstrated that the decline rate was higher in the bilateral group. Another very interesting study that I want to draw your attention to is that by Sujita. We mentioned that in our review article, which is actually in Fertility and Sterility some time ago. The Japanese authors here, they demonstrate that originally after cystectomy, at 1 month after surgery, they observe a significant decline in AMH, but then at 1 year after surgery, they observe that there are two different trends, two different groups. One group they call the increase group, which means that the AMH values increase to statistically significant higher levels compared to 1 month. And then a minority of patients tend to have a sustained decrease of AMH. And what I found very interesting in this study was that when they histologically looked at the number of the follicles removed during surgery, they observed that the number of follicles removed in the increase group was actually higher than that in the decrease group. So an interesting finding, how they try to explain. They say that, look, when you do a cystectomy, certainly you're going to remove some degree of, healthy follicles, but through some mechanisms that I will mention later, there appears to be the recovery. Okay, but in a number of patients, potentially mechanisms such as ischemia or low blood supply may lead to a persistently low AMH values. So that is an interesting finding. How does that AMH recover if it does? Well, that's not very clear. Possible mechanisms that are postulated in the literature include surgery-induced inflammation, leading to some sort of reorganization of the follicular cohort and therefore follicles transitioning from silent to active state in order to compensate for that original decline in AMH. And let us not forget, folliculogenesis is thought to last 180 days. So that may explain why a recovery after 6 months is observed. For non-excisional approaches, these are developed to spare the ovarian parenchyma. Therefore, one would anticipate that there's no drop in AMH after surgery, right? But that has not been proved in the literature. For example, in the recent multi-center Italian study, Nicola Dalterio and the other guys, they find that in the first 3 months after diode laser use, they observe a significant drop in AMH, but then it recovers 6 months later on, coming to actually beautifully confirm the earliest findings by Professor Roman on his plasma jet original research, where he also observed, for some peculiar reason which he was kind of unable to explain, an initial drop in the AMH at 3 months, which then reassuringly tends to recover. So it may well be that other mechanisms, such as postoperative inflammation, may be involved in an initial drop in AMH. Comparative studies, RCTs originally favored ablation. For example, we know, we have this study by Massimo Candiani. It's a lovely study comparing cystectomy with CO2 laser. In terms of AMH, the authors at 3 months demonstrate that both approaches caused a significant decline in AMH compared to pre-op value. However, that was significantly more in the case of CO2. And the Greek study by Professor Pandos, that Dr. Casali mentioned earlier, demonstrated that the 3-step approach with laser compared to 1-step stripping led to a not statistically significant decline of AMH at 6 months. So that was better, clearly, in terms of AMH compared to 1-step cystectomy. But then also size matters. This is also another RCT by Giampaolino that demonstrated, interestingly, that if you have to deal with smaller endometriomas, less than 5 centimeters, probably cystectomy and ablation does not really, that's talking about bipolar ablation, right? Does not differ a huge deal in terms of AMH. But if you have to deal with bigger endometriomas, ablation is more protective in terms of cystectomy. I personally would have to, express my concerns regarding how easy it is to fully ablate a large endometrioma that is 8 or 9 centimeters. I don't know. But that's the findings focusing on AMH. And also the laterality is important. Another group found that if we're talking about unilateral endometrioma, no huge difference between ablation but with bipolar and cystectomy. But if we're talking about bilateral, it's maybe better to avoid cystectomy. And then let us have a look at the very recent Cochrane study that is actually comparing excisional versus ablative, including all the ablative approaches. Okay, this is a very recent study. What they found actually 3 months, 6 months after surgery, they did not demonstrate a superiority of one approach over the other. They then conclude to say something very generic, such as the effect is uncertain, although it appears that ablative approaches may be better in terms of AFC compared to cystectomy. Their effect on AMH is not clear, needing further RCTs. This is an interesting study. I want to just food for thought, really, because when I found this study, I was really interested about the findings. When do you do the cystectomy? Does it really matter what stage of the cycle you do a cystectomy? Well, this group of Japanese authors, they demonstrated that if you do the cystectomy at the late luteal phase, that leads to a significantly, look at that, less decrease in AMH 1 week and 6 months after surgery. How is that explained? When I look at the discussion, they postulate that it has to do with reduction of inflammation and better cleavage plane during the late follicular phase. But I have to mention that an observational study that I also read did not confirm those findings, but that was an RCT, so I had to mention. Moving on to the other extravariant localizations for superficial peritoneal surgery, not a huge deal of information. I found this study from Goodman and Tommaso Falcone and the other guys. They demonstrate not statistically significant differences between controls and those that had peritoneal endometriosis treated by surgery. 1 and 6 months after surgery. For deep endometriosis, this is an Iranian group by Saeed Al-Borzi and co-workers. This is actually still in press. So I'm mentioning that, but what they found is that when they stratify the patients according to the disease location, be it isolated OMA or deep endometriosis with OMA or deep endometriosis, they observe the most of a decline to be actually in the combined deep endometriosis and OMA group, which may be reasonable if one anticipates that treating the ovary combined with extensive adhesion lysis for deep disease, therefore potentially messing with the blood supply to the ovary, that may be seen as a reasonable outcome, really. Okay, so moving on to really the last part of our results, which is categorizing our AMH patients according to the pre-op AMH values. We have these categorization to normal, low, and very low according to the values that comes from cancellation rates in IVF, but we use that. Can we use AMH values to actually say what are the chances of obtaining a pregnancy after endometrioma surgery? Well, there is such a study that really looked at that. Patients that had endometrioma cystectomy, they were stratified to high and low AMH groups and looked at cumulative pregnancy rates during a 2-year follow-up. They identified that preoperative AMH value was strongly associated with having a spontaneous conception after surgery. And look at that, at all times during that 2-year follow-up, pregnancy rates higher for those that had AMH more than 2 nanograms. And actually, in contrast to the Crestani paper, they found that the higher AMH decline was in that with a low AMH group. And what is also very interesting, they identified the optimal preoperative AMH value to be around 3.6 nanograms per ml. Another Asian group found a very similar value of AMH to be around 3.7 nanograms per ml in order to achieve a spontaneous conception. Look at that, pretty similar. If you have a high AMH before surgery, your chances of achieving a pregnancy after endometrioma cystectomy are much better. And another finding that is of interest here is they also demonstrated that with advancing disease, stage of the disease, revised ASRM, the AMH level goes down, meaning that potentially if you see a patient with endometrioma and a very low AMH, you may anticipate to have a kind of, higher stage disease, taking into account the limitations of non-invasive screening. What about IVF after endometrioma surgery? Do AMH values count? Well, we know from ESHRE that we don't routinely operate on endometriomas before IVF because you may do harm, but eventually some patients you're just going to have to do surgery either because they're very symptomatic or big endometrioma, what have you. So they demonstrated that for those patients that got pregnant through IVF, the AMH values at 1 year after surgery were significantly higher in those that succeeded a pregnancy compared to those that failed the pregnancy. And also that finding here demonstrated that the postoperative decline rate at 1 year after surgery again was associated with the chances of achieving a spontaneous conception, meaning that if you have a significant decline of AMH at 1 year, you're more likely not to have a spontaneous conception and you're more likely to have ART. So, it's not only the AMH pre-op, but also it looks like, the decline rate of AMH after surgery may play a role, although whether you're going to have to recheck your AMH just for that reason remains, a matter of question, taking into account various factors. And of course, it would be useful to have a pre-op AMH value to cut off to predict diminished ovarian reserve. Diminished ovarian reserve, as per Bologna criteria, will have less than 1.1 nanograms per ml. It is useful for the IVF setting because we know that these patients are poor responders. And this finding find that if you do a unilateral cystectomy and you have an AMH of 2.1, this is your cutoff to predict the chance of developing diminished ovarian reserve. But if you do bilateral cystectomy, it's 3 nanograms per ml. And look at that. It is important, the diminished ovarian reserve, because if you have diminished ovarian reserve at 6 months after surgery, your cumulative pregnancy rate is always lower compared to those that did not have diminished ovarian reserve. Plus, if you end up needing to do IVF, as we said earlier, these patients are poor responders and they do worse in terms of IVF live birth rates compared to idiopathic poor responders. So that is also clinically significant. Deep endometriosis, no colorectal involvement. Some studies here from French groups. This one demonstrated that if you have preoperative AMH more than 2 nanograms per ml, we're talking about, I'm coming to an end, I'm sorry I've overused your time. Without bowel involvement, you do a pre-op AMH of more than 2 nanograms per ml. You have increased chances of spontaneous conception versus ART, although no difference in live birth rates. However, 30% of those patients had cystectomy. And in another group, again, comparing first-line surgery versus first-line ART, they demonstrated that if you have a low AMH preoperatively, first-line surgery may be linked with an improved pregnancy rate and live birth rate compared to ART. This is demonstrated here. Finishing with the last original study, again coming from Rush Roman group, that is focusing particularly on patients with colorectal endometriosis. What they demonstrated is that preoperative AMH in those patients did not affect the pregnancy rates and live birth rates between patients with normal and low AMH groups. Of course, various limitations need to be taken into account. The young age of that cohort being around 30, and the small number of patients in the low AMH group, in the very low AMH group, therefore potentially affecting the results. But certainly they conclude that bowel surgery for those patients may be a good option, taking into account that they're likely to be poor responders in the IVF setting due to low IVF. We conclude our paper by suggesting that the relationship between endometriosis and AMH is a rather complex relationship. Ovarian endometrioma per se, evidence suggests that it's linked with lower AMH values and potentially a higher decline rate over time. Endometrioma surgery will have various approaches, excisional and non-excisional. A higher decline of AMH may be anticipated in the excisional approaches, although recent Cochrane meta review did not confirm that. Recover AMH is anticipated to recover to a certain extent, particularly in the late preoperative period. However, other factors should be taken account, such as the laterality and other factors. With regards to methods of hemostasis for ovarian endometrioma, originally thought that non-thermal methods are superior. However, recent RCTs may question that. We also found that for ovarian endometrioma, preoperative AMH is useful in predicting pregnancy rates, live birth rates, chances of developing diminishing ovarian reserve, but also the trend of that change in AMH after surgery may also be particularly useful in predicting the fertility outcome. Therefore, it's also particularly in our setting useful in deciding cryopreservation methods preoperatively according to various factors such as availability and all that. For extravariant disease, we have rather limited evidence. For superficial endometriosis, it appears that this phenotype may have limited effect, if any, on AMH, and equally for superficial endometriosis surgery can say the same. For deep endometriosis, it appears that it may exhibit a gonadotoxic-like effect on the ovarian reserve, and this is likely to be linked with the severity of the disease. And surgery may also hamper the AMH, potentially through extensive adhesion lysis, causing a reduction in the ovarian blood flow. A combination of deep endometriosis with ovarian endometrioma surgery may be the most aggravating in terms of ovarian endometriosis. And the role of AMH in those deep endometriosis patients is probably less well established, and I just presented it, very limited evidence here. As with every endometriosis, I'm closing here, every endometriosis research, we have to take into account the limitations of evidence come from the nature of the disease, the nature of the studies, heterogeneity, etc. But we also need to remember that a reduction in AMH does not necessarily mean a reduction in fertility of the patient. It is very important. More research is needed, particularly for extra-ovarian localizations. And with that, I would like to thank you so much for giving me the opportunity to present a narrative review article. And I would like to also, if that is okay with Dr. Ghazali, invite you to our podcast, which is not as good as yours, but is also useful, I believe. It's called Endo Talks, and we also strive to present some research pertinent to endometriosis. That was me, and thank you so much.
Thank you very much for that very comprehensive and detailed presentation. You clearly know all the evidence very well. I think what I need to do is to go back and watch this a few times to digest. I think one take-home message from all of this should be that a reduction in AMH doesn't mean a reduction in fertility, and that interpreting AMH levels is not as easy as people think. And particularly importantly, I think, is doing an AMH to test your fertility is not right. It really doesn't tell you anything. And I know that some of our own colleagues have not been able to resist the temptation to test their own AMH to see if they are fertile, or how likely it is that it just does not tell you anything. Unfortunately, we don't have time to discuss and explore, and we don't have time to present the other two papers. We'll leave them for next month. So thank you very much again, Georgios, and I invite all of you to join us next month for the 6th of August. Yes, we're already in July. 6th of August at 6 p.m. UK time. Thank you very much. And thank you to the team. Flo, I thank you particularly for putting everything together.